So it's my pleasure to present you this case we performed a few months ago at Montreal Heart. The learning objectives we're going to discuss with the panel here and the audience are going to be the early identification of patients that will need emergent mechanical support device, the timing and the choice of those mechanical support device, and the importance of revascularization strategy and complete revasc in ACS patients presenting with shock. So the patient was a 58-year-old male. He had chest pain while playing hockey. He had a crescendo angina since 2 weeks, and the cath lab was activated from field. Patient was brought to the ER by the paramedics. This was his EKG, so you can see a ST segment elevation in the AVR leads with a mirror sign in all the other leads. His BP was 90/50 millimeters, heart rate 90 beat per minute, great hinge, cold and motile skin. Patient was obtended. Therefore, he was semi-electively intubated before angiogram, and patient was resuscitated and immediately transferred to the cath lab. The surgical team was advised at this point that there was this patient in the ER due to several high-risk features and the potential need for advanced hemodynamic support. During the transfer to the catheterization table, unfortunately, the patient coded. The chest compression were started, and as the interventional team was already inside, and the echocardiographer was called. So, what do you do next? Would you, as it's a young patient, put a support device or perform emergent salvage angiography first?
So, would anyone in the panel consider starting right away with a support device, or would you get the coronaries first and then choose what your next move would be?
I think I would go for choreoangiogram and urgent revasc. At least with that ECG, I think we need to open up whatever we can and then decide. Obtain at least TIMI3 flow.
Okay. Dr. Coutu had a comment?
I would stabilize the patient first. If the surgeon is there and we have cannulas and everything, we can do percutaneous ECMO. Stabilize the patient and do the angiogram.
I think the concept is to bring the patient to the cath lab where you can do both, actually. So, I mean, the patient, I think one of the mistakes is to try to do everything in the ER, which looked like a third world country when it starts to ECMO and hemodynamic support. So I think you bring the guy to the cath lab, and then you can do both. If you need to stabilize first, you have a surgeon in the room. And I think, but I think the key thing is to bring the patient where you can do what you need to do quickly, optimally.
For us, it really depends upon the time of day that the patient presents. So if it's during the day and there's a perfusionist in the hospital, the patient will come up to the cath lab, and in a patient like this, who I assume was young, we would put them on percutaneous ECMO in the cath lab. Our group, as interventionalists, we actually can do that without a surgeon in the room.
We've talked about ECMO, but I think Impella is another option if it's available in your center. Balloon pump, it's quick to put if you're already in the lab and waiting for ECMO. So I think one of the things is you need to, because to do angiography and to be able to do a PCI, you need to have some relative stability before. So I think you need to address this first, so you'll be able to do a better job probably after that doing a PCI if you need to.
I think it's important is how fast you can get the ECMO going. I mean, I've seen many cases where they turn around very quickly. They're in shock, left main, you open it up. So personally, I would do an angiogram right away, know what you're dealing with, revascularize it as quickly as you can, and then when they have time, then
at least put the balloon pump before?
I wouldn't. I would try to open the artery as fast as I could, and then once I got flow, then I would add something else. I'd be on the phone. I think it's the right thing to do. Call the surgeon or call your team, who's ever involved in doing the Impellas, or if you're doing percutaneous ECMO. But I think opening that artery, and I've seen lots of cases where they dramatically turn around. With just restoring flow, and so I wouldn't waste time. All of a sudden, you have trouble with the ECMO or the Impella, and then just more myocardium's lost. And I think getting it open and then dealing with it—that's my personal preference.
I think in our center, the patient has not reached the level of a crash and burn, and there are still things that can be done that's simpler than an ECMO, I think. I think at the present time, if opening the artery and sticking a balloon pump can save, but you got to be versatile and ready to move and escalate. But I think at this, in our center at least, we wouldn't go right away for the ECMO if the patient still has a blood pressure and you're able to keep the patient alive up to that point.
Stefan, correct me.
This guy's arresting on his way to the cath lab, correct?
Correct.
He has no pressure at the point. Is he?
He coded.
Is on chest compression now?
Yeah, he just coded.
Oh, so that's ECMO, right? We would have done ECMO then.
But Stefan, here in the room, do you feel like this guy his presentation is acute? Do you feel that this should matter? Like, I do agree with Chris. This guy came in, he has a 30-minute chest pain, he's low pressure, he arrested coming in. Don't you feel that this guy has a chance by opening it up to turn it around? Yeah, compared to the guy that comes in with Q-Wave and ST elevation Q-Wave V1, V4 after 9 or 12 hours of chest pain. Does that matter in your allocation of resources, going to ECMO being, in my mind, a big thing, a big clinical decision?
I think you're right. I think the point is, how much are you able to restore spontaneous rhythm and a decent blood pressure with medical therapy is your key entry point to the algorithm. And in that case, even if you arrested, if you give epi and you have a pressure at some point that's running in the hundreds, he's tachycardic, I think everyone in this room will not call for an ECMO. We'll shoot right away the coronaries and we'll start working, right? But if we have done that, and we're still running and we have no blood pressure and the tube is in and everything, it's a different ball game. We're not talking about the same patient at all. So it depends on how you were able to bring the patient back to life. Are you dealing with a patient who was arresting or a patient who's still alive?
I think this, Stefan, I think this case illustrates that there's no single correct answer. All of us have done both. What we've done is PCI on Lucas, and the patient gets immediately better once you restore flow. Other cases, you have to call the ECMO team or Impella team to do this. So I think it's case-by-case basis rather than generalizing this particular case, what would you do each time? And again, it depends on how comfortable you are and how quick your center is in terms of ECMO implantation. Impella, are you comfortable? If you're not comfortable, then you're going to have to shoot the coronaries. If you are very comfortable and you can put it in within 2 minutes and the system is there, then obviously go with mechanical support.
So clearly it's hard to come to a consensus on this case, but Fabien, tell us what happened.
So right and left femoral arterial and venous access were obtained, and we performed the angiogram. So here is the angiogram. It's not running. Okay. No, it's not running.
While you're trying to get that running, just a quick question. Did you go straight up with the guide? And if so, why an XB35 or whatever, given the fact that your ECG shows pretty much left main occlusion?
Yeah, we went with a guide directly with the XB because we thought it could be also 3-vessel disease with the inclusion of other vessels. So.
Kevin, what was your problem with the XB?
Well, I mean, if you have a short left main or a left main occlusion, I would think that a JL35 or JL4 would be a safer guide option as opposed to an XB guide.
In your hands. If you have a complex
in your hands.
Then you're stuck with not much support.
I can still get away with it.
So this was the starting angio. We started under chest compressions. You can see the guide going up and the first shot on the right. So we had clearly no flow, and we tried to put a wire in the LAD. After 1 minute, we were able to put a wire in the LAD, and we started to balloon the proximal LAD. And on the right side, you can see the angio we have. So what would you be your next point at this point? Would you perform FFR? Would you put now the mechanical support device now that we have a flow, or would you perform emergent CABG or emergent PCI?
Let me ask you first, did you guys restore some blood pressure with revascularizing slightly?
Yeah,
or
well,
there was no blood pressure at that point?
There was a blood pressure at that point. So we reestablished flow, and there was some blood pressure.
So let me send it to the panel. What are your thoughts at this point?
I think we go back to the first question that we asked. At that point, how long would it be to put an efficient support device, and what do you have in your cath lab, which you can put in a few minutes? So for most of us, a balloon pump will be already available and would be in a minute. If you have the ECMO readily available because you call your surgeon, is in the house, and go ahead with that because it's more efficient, definitely. But it's a question of time and expertise at that point.
Yeah, I mean, personally, I'd open that artery, stent it as fast as I could. I'd do that in a minute, and then I would do something. Then I would call for that. I wouldn't. I've got the artery's blocked. We know times myocardium, get it open, and then you may not have to even. I've seen people, like I said, even at this stage, dramatically reverse their state by opening the artery. So I wouldn't wait. I would open it, and then I would do, once I as fast as I could, then I would do something else.
Maybe we could get the opinion of a surgeon on this. How would you guys feel about going to the OR?
Why wouldn't you just open it by doing an angioplasty?
Yeah,
I would. The guy's not putting in a stent. Just do an angioplasty and get him in.
Because you might open it and then it might close.
But if you get to the OR immediately, like the surgical team should be called once this guy arrested.
Yeah, I mean,
right? Hopefully by the time you've opened the thing, the OR is ready to get, this guy needs to go to the OR ASAP. That type of lesion like that.
Yeah.
So you want to
I can tell you in our center, it would take an hour to get to the operating room. And I can tell you that, over the last 15 years, and we probably see a couple of these, probably a few a month, and they never go to the OR because if we wait, they're not. It's going to take an hour to be revascularized. Their ventricle is going to be pooched.
Yeah.
So open that artery, stents in, and then you haven't. Like at the end of the day, say you open it, and it's got diffuse distal disease. Then you've opened the artery, you've got flow, and then you can, at your leisure, a week later or a month later, take them for bypass if they have a high syntax score or they need that. But I think right now waiting is, I think, the worst thing you can do. I think you open that artery, you put a stent in, you get TIMI-3 flow, and then you assess everything else. You assess their blood pressure, decide about support, balloon pump, ECMO, Impella, and then assess the coronaries after that. And do they need definitive therapy from bypass or other PCIs?
Yeah, and I agree with the fact that, it's a balloon pump rarely hurts in those situations. First of all, if you got to be upsizing to either the Impella or the ECMO, you might as well just do your access. Why don't you stick a vein? Why don't you put your balloon pump so that you're ready to escalate in the support afterward, and you already have something ongoing, because everything else will take at least 2 to 5 minutes to set up, whereas a balloon pump can be put in less than a minute. So you got to be thinking about what's available, what's next. And I would think that in the wait, and if you're like watching the pressure going down and hoping the surgeon will come fast, that'd be like stupid, right? So you got to be doing something. And obviously medical therapy is there. In those situations, like the vasopressor are flushing, where you're running fast, and then at the same time, you do whatever you can in the coronaries. I mean, the likelihood is that you're not going to watch this left main and think the surgeon could do a better job. You got to be doing something, right? So it's just common sense. I don't know if anybody has been in that, but these are high emotional situations. For those who don't do PCIs, you got to be. We'll tell you that we're emptying our adrenal arteries, our adrenal glands right away, right?
So just to your point, Stefan, I was in this situation the first years when I came back my fellowship, maybe the second call, where I have this 50-something years old guy with distal left main, and then I open it with 3 wire and all the branches. So now, because I don't want to look like a loose cannon, I say, I will call your surgeon. And then the reality and the practical the practicality of sending this guy to the OR turned me off forever of doing that. I mean, first of all, you need to keep the wire in place. You don't want to remove the wire.
Yeah.
So you have a sheet actually in place with 3 wires that you have to tape on the legs to go to the elevator, to stay sterile, the patient arrest, and then you need to open the chest on 2B3 or whatever the blood thinner you give, and then if the patient didn't arrest in the meantime. So it's really difficult to do that efficiently without removing the wire. So I will say that this may be good for long term, but it's wishful thinking to believe we can achieve that with a good outcome.
So it would be good to know from a surgeon standpoint, would they take a patient like this to the OR? And what would you quote the mortality rate would be?
Hi, Fuad Musa here. I'm actually a surgeon, so this kind of helps. Sunnybrook Hospital. We've been in this situation a couple of times, and I think the key to the discussion was what you said at the very beginning. Just make all the calls, make sure everybody's aware, available to come around, have a look. And it really does depend on time of day. If it's 4:30, 5 o'clock in the afternoon and there's an empty operating room, we can get them to the operating room in about an hour and we can get them revascularized. And we tend to bring our interventionists to the operating room with us to manage wires and to see what's happening. So as a surgeon, a young patient, this kind of scenario, we would not hesitate to take the patient in the operating room, whether or not they're on 2B3A inhibitors, particularly if we have the discussion ahead of time and say we can get them open within 2 hours. But certainly if you're on the table and you have your wires in, the first, most aggressive and safest thing to do is to open the vessel right there and watch how the patient recovers. Whether you angioplasty them and give them a couple moments to see if the vessel reoccludes, or you angioplasty them and stent them, that's what you do. That's what the heart team is for in the cath lab. So we have had these situations and we've had very good results either way.
I think if you look at it from a surgeon perspective, but it's always the same if you are in the OR, in the cath lab, and it's knowing what are your options, what's available, and what's the reality of your specific environment. Because you know how, as a surgeon, you know how long it's going to take for you in your hospital to take the patient from the cath lab to the OR, what's reasonable time. I know that in my center, I have limits, so I cannot bring the patient inside an hour to the OR. So for me, if I see a patient like this, I would say try to reopen the artery because I know that I won't be able to get to the artery as soon as I would want to. But maybe in some other centers, it is different. So you really have to know as a surgeon, but also as a cardiologist, what can you do in your own center? What is your area of expertise? What is the technology you have access to so you can turn around very easily? For some center, it's going to be a balloon pump, an Impella, an ECMO, it depends. But I will reinforce what you just said, that you have to call everybody in advance and talk about those cases. Recently, I had a case like this with my colleague, Dr. Palisaitis, who's just there, and the guy was coming, it's a girl, it was coming right from the ER to the cath lab, and everybody was there, right from the start. I was called at the same time as he was called, or almost, with my perfusionist, echographist, and you went to the cath lab, everybody together, and took a look at the angiogram and took a decision together. I think that's the best course of option. And then knowing what you can do reasonably in your center, then you can decide. But you have to know what is the reality of your own center.
But I think the reality is, which is over here, I think the reality is, obviously, as stated, the earliest you're going to get to the patient from a surgical perspective is an hour. And that's as quick for most center. And that's not realistic. In terms of PCI, we've come so far in terms of techniques and stent and so forth. In this type of lesion, it's a very low risk a type of left main lesion. And if you could open up the vessel immediately, why wait an hour? Probably average would be an hour and a half to 2 hours as quick as to get to the operating room. So why not open that vessel immediately with PCI?
I agree. There's never going to be any harm at opening the artery at this point. You're not preclude if distally there's something more more complex. You're not precluding bypass by restoring flow. It's an acute problem. The left main has been acutely occluded for half an hour and an hour. Just take care of the acute problem. What was there before was not giving any real problem before. You know, if it's an anatomy that's more suitable for bypass surgery, can always be done later. But I think, right, an hour is an hour. If left main occlusion is an hour, it's an hour that shouldn't be there.
And Benoit, the case, Don, and also Benoit has a good point, but when you're, what I've seen in my practice, and maybe it has changed with the minimally invasive guys and everything, but in these very unstable patients, the guy will end up with 4 veins. And I wonder if that's really what we want to do. Because he's super unstable, they go on pumps, they wish they want to do a quick surgery, they want to reduce their pump time, because usually they won't do that on the beating heart. So, and all of that, and then they say, let's get the guy alive and let's put veins. Now you're dealing with a 50-year-old guy who's gonna have 4 veins, right? So in my mind, I think we're in 2016, we're beyond that. So we gotta be thinking differently.
I mean, maybe just a quick comment before, because Benoit touched a good point. It's an acute situation, which means that when we look at the literature, left main occlusion is 50% mortality even when you succeed to stent. So just be honest here. So if you don't stent, you probably have 100% mortality, but if you delay from 1 or 2 hours, it's probably 80% mortality. Yeah. So the reality is that acute. If it's a guy who comes on VTAC with EF of 20%, chronic CTOs, everything, you put an Impella, and then you can do whatever you want. But the acute state is, it's totally different. It's high mortality immediately. It's not delay. So sorry, done.
Just to answer your comment, if this guy goes to the OR and does not get an IMA, it's unfortunately not very good care. So if this guy does make it to the OR, we've had these situations before. You put him on pump, take the ITA down, and make sure at least he gets a lima to that LAD.
So let's try to move the case forward. We'll just get one last comment from Don.
So you've obviously succeeded with this case. It's wonderful. We just seen the opinions of everybody and nobody agrees about anything, right? I just want to bring one point. This patient has no pulse, no blood pressure in the emergency room. There was a comment made by Philippe earlier on that the emergency room is a third world country, okay?
No, he had a pulse at the ER. He coded when he was in the cath lab.
Oh, he coded in the cath lab, okay. Okay, let's move it along.
Okay, tell us what happened, Fabien.
No, but your point is good. Keep going, because it's still a third world country.
So I just wanted to say that, as we have a panel of cardiologists, interventional cardiologists, and surgeons, we have no intensivists here, okay? What will the intensivists say if the patient codes in the emergency room? We say time is muscle, but what about the brain and all the other organs, right? So we have to preserve those other organs. That is priority. Everybody, if they were intensivists, would say this patient needs ECMO immediately in the emergency room if, to your point, you are organized to do so. Thanks.
Okay, Fabien?
All right. Can we have the images? So what we did was implant a balloon pump. Can we go back to the slide? Yeah, thank you. So we implanted a balloon pump, and during the meantime, we performed balloon angioplasty of the LAD. And as you can see on the right side, the LAD was open, and we had good flow, and BP was getting better. The other question here is that we have a CT of the left circ, and we're talking a lot about complete revasc in shock patients with ACS. What do you think of the left circ, and would you treat it acutely, or would you defer it?
So what's his blood pressure now that you've opened up the LAD left main?
What?
What's his blood pressure now?
The blood pressure was like 90, but he was under high doses of vasopressor. He had IABP.
And what is the LVD? Do you have an LVDP or a sense of at least the filling pressure, or just?
No, we didn't.
No, it's okay.
I think at that point that the job is not finished in the culprit, and before running after other ones, you have to finish the job in the culprit. At that point, it's at that point that you have to decide if you send your patient to surgery.
That's
because
exactly the
you have
point
flow
we're
into
gonna-
your LED. Is it a normal flow? It's hard to see from here. However, it's open. So the whole story about leaving a wire in and sending the patient for a 1 hour journey in the hospital is there. I don't think you should do it, however, because we can fix that. We can fix that easily and take care of the other ones after. So I don't see why surgery should be an option in a patient like that. If you cannot open the left main or the LED, that's another ballpark. But in that situation, you can finish the job over there.
Yeah. So at that time, the surgeon was on site. So we did her team decision, and he advised to do PCI because the team wouldn't be ready within an hour.
I guess
so what?
The question, though, is I think what you were alluding to is the fact that you've got a patient in shock, you've opened up the culprit, but now this is where we potentially have a free-for-all. If you're still in shock, you go after multivessel PCI. Maybe Stéphane would probably go after the CTO of the CIRC-OM in the same setting, but I think that at this point in time,
we're not even sure it's a CTO.
But you're raising a good point. I think the data shows that multivessel disease and the presence of CTOs is a huge marker, a huge predictor of mortality and shock, okay? Because they have less reserve. However, we have no prospective data in even observational data that says that in acute setting, treating these patients will get them out the wood. We don't have that. And I would say that it is probably the wrong thing to do because a CTO needs assessment, needs time, and it seems to be like a slam dunk, but it may not be a slam dunk. So you have to be thoughtful. Get your job done. Because that's obviously not the culprit, this CIRC, right? So get this LED done. Get the guy out of the lab. Then analyze your CTO. Then do it on the second time. You don't want to drop another 200 of contrast when a patient who's not peeing right now because he's in total shock. So you got to be thoughtful about what you want to do. Get your objective clear. Get this guy out of the lab alive, and then step up and do your thing. But I wouldn't do the CTO, not at all.
But it looks like there's collateral from the LED as well. So
yeah, absolutely. So for now,
you try to open up the CIRC, you perforate something, and now you've done all this great stuff with the left main LED, and now you perforated the CIRC. I mean, it could happen.
It could happen.
And now it's got collaterals. It's not. It's old. So I agree with that 100%.
They have no reserve. Tiny complication from your CTO. Just the ischemia that you're going to create by injecting contrast. If you go in the false lumen and you lose a little bit of collaterals, that might be just enough to tip them over.
So I think we have a consensus that we would not go after the circumflex, correct? Tell us, Fabien, what you did.
So we went for the left CIRC quickly, but the idea was to just try to put a wire if it was functional CDO and try to reopen it if it was easy. As you can see, when we were wiring the left CIRC, the LED reoccluded, and therefore we decided to go for the stenting of the LED and the left main.
I guess that the rationale to go after that circumflex before stenting the left main was to facilitate the passage of the wire and treat and finish with the stent in the left main, which what we usually do in the non-acute setting.
And if you show this previous shot, the wire is in a tiny OM, and actually just beyond the tiny OM, that's where the proximal cap is. That's a CTO that's right at the bifurcation.
Yeah, that's why we
and
stopped.
You're opening just this very small OM that's not providing
but moreover,
much
we
flow.
were subintimal.
So you guys decided just to go ahead?
Yeah, we went to for the LED and the left main. You can see here that we have a good result now on the left main and the LED. And the question now is, we have done the job on the left side. We can shoot the right to see how it is. So this is the final result of the LED.
Do we see the right from the? Yeah.
And this is the RCA.
So I guess your job is not done yet. So what did you do next?
It depends.
How is the patient?
So the patient, so at that time, the echocardiographer came. We performed TEE. You can see that there was no mechanical complication, but the LVEF was really low, and therefore the blood pressure was also low under vasopressor and IABP. So the other question is what to do next. Would you transfer the patient to the intensive care? Would you perform the RCA PCI? Would you put a more aggressive mechanical support device, or would you do both PCI,
Maybe we
RCA,
can try
PCI,
a
or-
show of hands. Anyone in the panel with the PCI, the RCA at this point?
You need to upgrade your support.
So everyone would go for support at this point.
Yeah, that's the first thing.
Excellent. So, Fabien?
So that's what we did. We discussed with the surgeon. He was there, so we decided to implant a support device. The other question now is which support device is going to be best for this patient in acute setting of myocardial infarction. Well, what does the panel think?
Who would choose an ECMO? Who would choose an Impella?
I think we saw by the LV is moving. It wants to reawaken. I don't think it makes a lot of sense to put a huge afterload of an ECMO. Personally, I would go with an Impella because I think we have, but not. You know, if you don't have CP or 5, I think it's useless. So you got to have to go for CP because otherwise 2.5 liter won't do it, right? So it's got to be a CP or a 5.0. Even a 5.0 would be even better. So I would like to have the surgeon come, do a cut down, put the 5.0, because this is likely to stay longer, right? So just by staying longer anyway, because you won't be, it's like a high-risk protected PCI where you do two pre-close and you get that out right away. It's going to stay in the groin. So I would do a good job, get the surgeon, open up, put a 5.0. If you might as well spend 15K, just do it right and give the right flow to the patient.
I think the decision regarding which mechanical support is quite complex. You got to know what the patient's hemodynamic is. And as well, I'm not an echo person, so I don't know if the RV is actually working at all because this patient has multiple CTOs and significant coronary disease, may have BIV failure. We don't know. If you put in, let's say, the Impella CP, I agree with the Impella CP or 5.0. The problem with those is if you have RV dysfunction, you're not going to get a lot out of those, and you may need Impella RP.
Put the echo.
So you may need ECMO. So you need a lot more information as well before you could decide on the proper mechanical support.
But how much information can you allow yourself to get in a situation like that?
I agree.
Yeah, so you have to move, right? You have to take a decision. So I don't know.
It's an LV problem, so I think an Impella would work, but it depends on your resources at your center. So we don't have Impella, but we do have ECMO.
Okay.
So we
But that's a key. Yeah, absolutely.
And also we can see it has at least moderate to severe MAR. Therefore, I think Impella is the way to go.
But you also have to make sure there's no LV thrombus. Obviously, it's an acute situation. Your risk there is extremely low. But in a young person, you got to be careful. You got to be extremely careful picking your mechanical support at this point. And I agree with Stefan. I would have done Impella CP. But all these things have to be in the back of your mind as well.
I think the RV contracts on this. It's not a completely down RV. So I would say it's probably a first step that if you have Impella, I think most people will go for this because it's a different. I think it's a level of invasiveness that's a bit less.
So what did you choose, Fabien?
So there was a mild dysfunction on the RV, and we discussed with the surgeon and the echocardiographer, and we decided to go for an ECMO. So we already had the cannulas on the right and on the left side. We just put it the perfusion cannula, and we put the patient under ECMO. The other question after that, the patient was stabilized with the ECMO, and would you do the RCA, or would you just leave the patient on ECMO and see how he's going and stage it?
So again, going back to the shock and patient in shock, would anyone consider the RCA at this point? You've put an ECMO, you've stabilized him.
Just a little try, or
what is the echo?
Can you show the right coronary again?
And EKG.
Can you show it again?
EKG and echo showed, you know.
Always remember that you can make it worse. If you lose that, you might be in big trouble.
Yeah.
It depends how much dye you've used already, how much time. You know, I think if you've given them 300 a dye already, you might not want to give them another 300. But I think looking at that compared to the circ, you might just want to just stick a wire in and see if it goes easy. And if it goes easy, you go for it. If it's difficult at all, you probably back off. That's what I would do.
If it is difficult, we call Stefan.
If you cross.
If it is difficult, we call Stefan.
Min, what would you do?
Stefan.
Just like your opinion.
I agree with Stefan. When we do CTO PSI, we don't just try and do it. It's going to get open. So we're not going to try and poke for 5-10 minutes and then just leave. If we're going to go after the RCA, as a group believe that when a surgeon goes in, the surgeon doesn't say, I'm going to try and bypass something. They're going to bypass something. So when we go in to do a CTO, we're going to do the CTO. Now, how aggressive we want to do in this particular case, I think I agree with Stefan. CTOs has to be done on a relatively stable patient. The patient became unstable because of the acute occlusion of the left main LAD. See if the patient stabilizes. Give the patient some time. It wouldn't be within 1 or 2 days. Give the patient some time. Obviously, if the patient cannot be stabilized, let's say for several days, half a week, then I would consider doing the CTO intervention, and I have done that because they could not get the patient off ECMO.
Okay,
But you got to give the patient a chance to recover.
So I just have one question, perhaps for one of the surgeons in the audience that do VADs. So we're a very big surgical VAD program, and we've had patients like this, and I mean, I think we all agree this is just due to the anterior and far cardiogenic shock. You got to wait for the LV to recover. Is a Centromag an option from a surgical standpoint?
Absolutely. We use Centromag quite a lot. So this LVAD Centromag be very, very good. But Impella is something that you could put in quicker.
What
so
is
this
a
is a guy that I'll put in Impella.
Excuse me. What is a Centromag?
Centromag is basically it's a levitating as kind of a magnetic kind of a pump that produces least amount of trauma to the blood, and you can connect as an RVAD or an LVAD. It's basically a pump that's basically magnetically levitating, so prevents trauma to the blood. And you can have a patient on it for over probably 6 to 7, 8 weeks. So what we usually do is we start with an Impella. If the patient needs Impella for more than 10 to probably 14 days, then we upgrade him to what we call the Centromag. They used to be called Levitronics. The company got bought by Thoratec.
And would you consider the 5.0 right away here? Yeah?
Yes, I would do a 5.0 in him, nothing less than a 5.0.
Yeah.
So just for the sake of time, I see from the CTO specialist, there's a consensus not to do the RCA, but Fabien, they went ahead.
Yeah. So under ECMO, the patient was more stable. We just tried with a wire, saying if we're able to cross easily, we'll just do it, and maybe it's going to help the patient. We were able to cross with the Gaia second, and therefore we performed the angioplasty with the.
So did this lesion
with these results?
Did this lesion comport itself as a CTO, or because quite frankly, I'm going to bow to the experts in CTOs, but when I looked at that, even if it was a CTO, it looked like a very short one, and I thought that I would be able to get through that. Now, maybe I misevaluated. So did it comport itself as a CTO? Did you have a lot of trouble getting through there or not?
No, we didn't have a lot of trouble. It was not like it didn't cross directly, but it took maybe 1 minute to cross.
But just because it's easy, it doesn't mean it's not a CTO. So you got you got different CTOs. Simon here pointed out from your previous angiogram, the first one you got collaterals already.
Yeah.
And again, you can see collaterals in severe stenosis. That's fine. But just because it's easily crossed with a wire, it could be a JCTO score 0 CTO.
So I just want to add one question. I'm a little bit amazed by the direction of the discussion in this STEMI patient, because I mean there's a strong advocate based on PRAMI data in STEMI to revascularize everything. And here we have a patient in shock in STEMI, which actually is the most intuitive to revascularize all the vessel. And we're picking the vessel that we're going to PCI based on a lower chance of success. I'm just amazed. I mean, maybe I interpret the data wrong, but I don't believe in PRAMI because I have my own reason. But in this particular case, it's probably the only case I wanted to do everything. So, and I agree with Don. This doesn't seem to be a CTO to me, but I would defer to CTO specialist.
Would you have tried the SORC?
But I think the nuance.
You would have tried the SORC?
Well, yeah. It's probably the only case I will try to rasterize everything in STEMI patient, and this despite PRAMI trial, actually. So I don't know if you don't do that in this patient. I think PRAMI should. It's because you reject completely defining a PRAMI, which I can't.
But
tend to agree with
Philippe,
that.
PRAMI is not, they were not in shock.
I agree, but just to be provocative.
The objective is to reduce further events. It had no impact on initial survival, right? Here we're not dealing with any fear of reinfarction. We're really dealing with, is he going to make it or not, right? So, and what's the big driver of making it or not at the present time, for me, is support. So if he has support and you have time to take a step back, reanalyze your angiogram, talk with the surgeon, do whatever I think it's okay. Because on the reverse, I've seen people misinterpreting the angiogram as a channel, and actually it's an epicardial collateral. And then they end up with perfing this. In a patient in a shock like this, that'd be a disaster. So if you're confident that you think it's a channel and you want to track this with a wire, be my guest. But be confident in what you're doing. And it's not the good setting because your adrenaline is like flushing as fast as the patient at the present time. So you have to be thoughtful about that. So
I think for the sake of time, it's really valid points, and a lot of controversy came out of this case, but we'll let Fabien conclude.
Yeah, so in this patient, we were able to remove the ECMO 5 days after the implantation. The patient initially did well. He was ambulant a few days after. Unfortunately, he died of sudden death 21 days after, probably from stent thrombosis.
Or myocardial rupture.
Or myocardial rupture. Or VT.
Yeah, a lot of reasons.
And then, so the key messages of this presentation was the importance of early recognition of shock cases, the importance of alerting all the team when you have a patient that you know that he's most likely going to code, and to have her team discussion for mechanical support choice and reverse strategy. The last part, which was more discussed, is the importance of complete reverse in shock. When you have all this, we think it's going to be the optimal care for the patient. Thank you.
Thank you very much.